Hello and welcome to AiMedRevolution, the science communication channel where we explore the latest advances in the use of artificial intelligence in medicine. This episode is based on a recent study titled Diverse Patients' Attitudes Towards Artificial Intelligence, AI, in Diagnosis, published in PLOS Digital Health. Before we begin, I want to acknowledge the authors of this article who have done an exceptional job. They are Christopher Robertson, Andrew Woods, Kelly Bergstrand, Jess Finley, Kaylee Balser, and Marvin J. Slepian from institutions such as the University of Arizona, Boston University, and the University of Texas at Arlington. Their dedication and effort undoubtedly provide us with an invaluable perspective on the complex topic of how patients perceive AI in the context of healthcare. Artificial intelligence is establishing itself as a powerful tool in the medical field. From tumor analysis to personalized treatment selection, AI has the potential to transform how diseases are diagnosed and treated. However, this change also generates considerable skepticism, particularly regarding trust. As various studies show, many patients prefer human doctors over automated systems due to greater trust in clinical judgment and the perception that machines cannot fully understand human needs. This study seeks to delve deeper into these perceptions, analyzing how different groups of patients feel about the use of AI in medical diagnoses. The authors not only explored preference for AI versus human doctors, but also evaluated how various factors of system communication and presentation could influence patient acceptance. The primary objective of the study was to determine how different groups of patients perceive the use of AI tools in medical diagnosis, and whether the way information about AI is presented influences the decision to use it. To this end, structured interviews were conducted with real patients, and subsequently, a randomized survey experiment was conducted using clinical vignettes that simulated real medical scenarios. The study was conducted in two phases. In the first phase, qualitative interviews were conducted with 24 patients of various ethnicities to understand how they reacted to current and future AI technologies in healthcare. Participants were recruited from clinics in Tucson, Arizona, and were asked about their medical decisions and perceptions regarding technology in medicine. In the second phase, a quantitative experiment was conducted with a larger sample of 2,675 patients, which included an overrepresentation of minority populations, such as African Americans, Hispanics, Asians, and Native Americans. Patients were exposed to different clinical vignettes that presented two options: a diagnosis made by a human specialist or a diagnosis made by an AI system. 8 variables were manipulated to evaluate how they affected patients' decisions, including the severity of the illness, the demonstrated accuracy of the AI, and whether the AI system was designed to listen and personalize the patient's experience. The main results showed an almost equal split in patient preferences. 52.9% preferred the human doctor, while 47.1% opted for the AI clinic. However, when the doctor explained that the AI had been shown to be more accurate than human specialists, acceptance of the AI increased significantly, with a 48% increase in the likelihood of patients opting for the AI. Additionally, the fact that the doctor actively recommended the AI option, presenting it as the established and easy choice, also resulted in a greater likelihood of patients choosing the AI clinic, increasing preference by 25%. Furthermore, it was found that including a personalization component, such as training clinic staff to actively listen to the patient, increased acceptance of AI by 27%. Another relevant aspect was the lack of significant impact of disease severity on the decision to opt for AI. That is, patients were not more inclined to prefer AI when the condition was potentially life-threatening, such as leukemia, compared to a lower-risk illness like sleep apnea. This suggests that risk perception was not a determining factor in the choice between AI and a human specialist. However, there were demographic and socio-cultural factors that did influence the decision. Older patients were less likely to choose AI, with a decrease in probability for each additional year of age. Similarly, those who identified as politically conservative or considered religion an important aspect of their lives also showed a significantly lower tendency to opt for AI. These groups, historically associated with higher levels of distrust in technology, seem to maintain their reservations regarding the introduction of automated systems in healthcare. In contrast, a higher educational level, was a factor that increased the likelihood of selecting an AI provider, suggesting that greater exposure to scientific knowledge may correlate with greater openness to technological innovations in medicine. There were also significant differences according to ethnic group. African American patients, for example, were less likely to choose AI, while Native American patients were more willing to opt for automated diagnosis. These differences may be related to historical experiences and levels of trust in the healthcare system, underscoring the importance of considering the cultural and social context when evaluating the acceptance of emerging technologies in medicine. The results of this study highlight considerable resistance to the use of artificial intelligence in medical diagnosis. This aversion to algorithms, also known as algorithm phobia, is reflected in the preference for human contact in healthcare contexts, even when AI has been shown to be more accurate. The results suggest that while AI has the potential to provide more accurate diagnoses, patients' perception of empathy and human understanding remains a critical component in medical decision-making. One of the most interesting findings is the positive impact that certain communication strategies have on the acceptance of AI. For example, the doctor's active recommendation and explanation of AI superiority in terms of accuracy can mitigate some of the skepticism. This underscores the importance of the physician's role as an intermediary and advocate for technology, where clear and convincing communication can make a significant difference in patients' willingness to accept AI intervention. It is essential for doctors to understand not only the technical aspects of AI, but also how to communicate its benefits in a way that makes patients feel confident and secure. Another key aspect of the discussion is the personalization of the AI system. The possibility of AI listening and adapting to the patient's specific needs stood out as a relevant factor in increasing acceptance. This indicates that for AI to be more widely accepted in the clinical setting, it must be designed to promote personalized interaction, capable of respecting and valuing each patient's individual experiences. An empathetic and humanized approach should not be exclusive to human doctors, but should also be integrated into the development of AI technologies. Regarding demographic and cultural differences, the findings indicate the need for differentiated approaches. Resistance among older patients, conservative groups, and those with deep religious beliefs suggests that AI implementation strategies should be tailored to address these specific reservations. This could involve ongoing education about the benefits of AI, as well as ensuring that the technology is used in a complementary way without replacing the human doctor. On the other hand, the greater acceptance observed among patients with higher educational levels suggests that an educational approach that promotes scientific and technical understanding of AI could be key to improving its acceptance in society at large. Finally, the variability in acceptance according to ethnic group also highlights the importance of equity and fairness in the development and implementation of these technologies. AI systems must be rigorously designed and tested to avoid biases that could perpetuate inequalities in healthcare. Additionally, trust in the healthcare system varies according to each group's historical experience, which must be taken into account when introducing new technologies that might otherwise be perceived as an extension of existing inequities. The implications of this study are clear. While AI has the potential to improve diagnostic accuracy and reduce inequities in access to care, lack of trust in these systems could limit their adoption. AI developers must focus on transparency, bias elimination, and the creation of personalized experiences for patients. On the other hand, doctors must be prepared to integrate AI into clinical care in a way that preserves patient autonomy and well-being. Training healthcare professionals to act as mediators between technology and patients is essential. In addition, clear ethical guidelines and quality assurance processes must be established to ensure that AI is used fairly and effectively. Acceptance of AI in medicine will depend not only on its ability to improve health outcomes, but also on the trust patients place in these systems. To achieve this, it is crucial that the technology is perceived as a complementary tool, working hand in hand with doctors to provide more precise and personalized care. In conclusion, although AI is poised to transform medicine, its adoption largely depends on patient acceptance. Trust and communication between doctors and patients will be key to overcoming current barriers. This study provides an important foundation for developing strategies that can improve the integration of AI into medical practice and ensure that the benefits of technology translate into better care for all. Thank you for joining me on this episode of AiMedRevolution. I hope you found this discussion about patients' attitudes toward artificial intelligence in medical diagnosis useful and interesting. Don't forget to subscribe to the channel and share this content with those who might benefit from it. If you have any questions or comments, I would love to hear from you. Until next time.